Hello everyone, welcome to PathoMed. Today, let us study about an important topic from clinical pathology, which is semen analysis. Before beginning with the semen analysis, let us see through a brief anatomy of the male genital system. So, this is the scrotum, which consists of testicle and epididymis. They are primarily the spermatozoa that are produced from the testicle. Testicle produces sperms from testicles, they go into the epididymis and they are stored in the epididymis for a while and they mature. The spermatozoa mature within the epididymis. So, this epididymis and testicle both together they contribute 10% to the semen volume. To the semen volume, they contribute 10% together. From the epididymis, the spermatozoa travel through this vas deferens. This tubular structure is the vas deferens. They travel through the vas deferens and enter seminal vesicles. These are the seminal vesicles. So, the seminal vesicle contributes to the major portion of semen volume. 50% of semen is made up of secretions from the seminal vesicle, and most importantly, it produces fructose. Fructose. And from the seminal vesicle, the dilated portion of the seminal vesicle is called ampulla, which is another storage area to the sperms. From here, they travel into the ejaculatory duct. This is the ejaculatory duct. Through the ejaculatory duct, they are thrown into this urethra, and the proximal part of the urethra surrounded by a muscular organ, which is the prostate. The prostate also contributes to the semen volume by secreting proteolytic enzymes. And the secretions of the prostate contribute to 40% of the semen volume. Importantly, spermatozoa produced from the testicles, stored and matured within the epididymis. From that epididymis, they travel up through vas deferens and enter seminal vesicles, which secrete many other secretions, including fructose, and contribute to 50% of semen volume through ejaculatory ducts thrown into urethra and the proximal part of the urethra surrounded by prostate, which is a fibromuscular organ. It also contributes to the semen volume by 40% and also produces proteolytic enzymes. This is a brief anatomy, brief idea. Let us begin with the topic. The structures which produce and contribute to the semen are firstly testis. It produces spermatozoa and testis alone contributes to 2 to 5% of semen volume. Secondly, epididymis. Sperms are stored here and they are also mature in the epididymis. This secretes sodium, potassium, glycerol, phosphoryl, choline, which acts as an energy source for sperms. And testis, epididymis, these together they contribute to 10% of semen volume. Thirdly, vas deferens, the tubular structures which carry the sperms. Sperms travel through vas deferens to ampulla, which acts as another storage area. The vas deferens secretes ergothioneine, which reduces chemicals in the semen, and fructose, which gives nutrition to sperms. Seminal vesicle, during ejaculation, they secrete nutritive and lubricating fluids that are added to the semen and contribute to 50% of the semen volume. They secrete many substances, most importantly fructose. Fructose also becomes the biochemical marker to know the function of seminal vesicles. Along with fructose, many other substances like amino acids, citric acid, phosphorus, potassium, prostaglandins are also secreted by seminal vesicle. Nextly, prostate. Prostate produces enzymes which are proteolytic enzymes. They are required for converting thick viscous semen. Normally, semen is very viscous. So, to make it very watery, so that it can easily penetrate through the cervical passage, which is called liquefaction, certain enzymes are needed to break down or liquefy the semen. These enzymes are produced by prostate, and this prostatic secretions they contribute 40% to the semen volume. Also, there are Cowper's glands, bulbourethral glands of Cowper, which secrete mucus, which gives viscosity to the semen mucus, but they contribute very small percentage. Let us come to the normal parameters of semen. These values are according to WHO 2021, which is the sixth edition recently released. First parameter is volume. After you receive sample, first you check the volume. Normal volume is about 1.4 ml. To give a range, 1.3 to 1.5 ml is a normal range. pH is 7.2 to 7.8. Sperm concentration. If at all a man produces 2 ml of semen at one ejaculate, concentration means per ml you calculate per ml how much sperms are present in 1 ml, that is concentration. So per ml it should be equal or more than 20 million sperms per ml, that is concentration. Whereas the count is the total number. If at all he ejaculates 2 ml at one time, to the whole ejaculate, how many number of sperms are there? That is the total sperm count, which should be at least equal to or more than 40 million per ejaculate. 40 million sperms per one ejaculate. Total motility, if at all you observe the semen sample under wet preparation of microscope, among after all the total sperms that you see, 42% should be motile, at least 42%. To be in a range, 40 to 43 is the range. Normal forms, that is normal morphology, should be at least 4%. Vitality means live sperms. Live sperms should be 50 to 60%. And WBCs are also present in the semen, which should not be more, which should be less than 1 million per ml 1 million. And there are two tests: mixed anti-globular reaction and immunobead test. These two tests will study in detail in immunological assay of the semen analysis in the later part. This should be less than 50% in both the tests, less than 50% of motile sperms with adherent particles. You perform this test when you observe under microscope, you find this motile sperms. So less than 50% of the motile sperms should have attached particles. Less than 50%. That is the normal parameters. Coming to the indications, why do you perform semen analysis? Widely known, popularly known reason is to investigate infertility. For example, whenever a couple is trying to conceive but they are unable to conceive, the first investigation as they approach a doctor is semen analysis, because semen analysis is non-invasive. It is the only non-invasive method. Female investigations are invasive. So first you perform a semen analysis, and also the male partner contributes to 30% of the problems. 30% of the infertility problems are because of the male partners. This is first reason. The second reason being to check the effectiveness of vasectomy. The male partner undergoes vasectomy to know whether the operation is successful or not. After you perform surgery, you ask the patient to come back after 12 weeks and you perform semen analysis. If there are no sperms, then the vasectomy surgery is said to be successful. To know this effectiveness of vasectomy, you do a semen analysis. Thirdly, paternity disputes. For example, a husband, he claims that the child is not born to him. So he has to prove his point. So he goes for semen analysis. If at all he is proven to be azoospermic, that means his semen does not have any absent sperms in his semen, then he cannot beget a child. On this grounds of azoospermia, he can prove that the child does not belong to him. So the paternity dispute cases are solved by semen analysis. And also in case medico-legal cases, for example, there is a alleged FIR of rape or sexual assault. You collect samples from the female victim. vaginal fluid or clothing are collected and they are examined for semen, presence of semen. If semen is proven to be present, then the rape is proven. Medical legal cases, you perform semen analysis. And also to select a donor, sperm donor. If at all a couple is trying to conceive and unable to conceive because of any male reasons, the husband doesn't have enough for sperms, oligospermic or abnormal morphology, they need a sperm donor. So the sperm donor has to be fit enough, or his semen has to be fit enough to impregnate the woman. So, in such cases, the sperm donors semen analysis is performed. And also in cases of artificial reproductive techniques, for example, the female genital tract problem is there, cervical problem or tubal blockage. So you collect semen from husband and oocyte from the wife. You fertilize it artificially outside the body and introduce the fertilized egg into the female tract. In such cases, before performing this technique, you collect the semen, you perform a semen analysis for IVF for intra-fallopian tube transport. These are the common indications where you perform a semen analysis. Now, how do you collect this sample? So, the sample, before collecting the sample, you ask the male partner to have sexual abstinence. That is, he should not participate in intersexual intercourse for a period of 3 days. Ask him to come after 3 days of this abstinence. If at all this abstinence is not maintained, it is less than 3 days, then his counts will be low. False negative will be there, low counts will be there. If at all the abstinence is for a very prolonged time, months together, then his motility will be decreased. And the semen is collected by masturbation and it has to be transported within 1 hour to the lab. So ideally the collection room, they are situated near to the testing center and the specimen should be kept as close to the body temperature as possible. And whenever semen sample is collected, the first portion of the semen sample, it is highly concentrated. It is highly concentrated in sperm count. So for this reason, the collection is not recommended by this coitus interruptus method. In coitus interruptus method, while performing the sexual intercourse, the male partner at the time of ejaculation, just a second before the ejaculation, he withdraws his penis and he collects into the collection tube or collection vial, the sample vial, sample box. So this method is not recommended because whenever it withdraws, there can be a chances that the first few portion of the semen will be lost. The loss of first few drops of the semen, first few portion of the semen will be lost, which is highly concentrated. So the semen sperm count can be falsely low. So this method is avoided. Coitus interruptus method is avoided. And also condom collection method is also avoided because the condoms, they contain spermicidal agents, they kill the sperms and hence it gives falsely low counts. So these methods are avoided whenever the sample has to be collected. Let us see the biochemical markers. There are three markers for seminal vesicle, prostate, and epididymis. Seminal vesicle, as we have discussed, it produces most importantly fructose. Fructose is the marker for seminal vesicles. Prostate markers, we have zinc, acid phosphatase, citric acid. Three markers for prostate, that is zinc, acid phosphatase, and citric acid. For epididymis, we have two markers, alpha glucosidase and carnitine. These are the markers, biochemical markers for the test for this function of semen, production of semen. Let us see the terminology involved in the semen analysis. Firstly, let us see the normal ones. Normozoospermia. Normo means everything is normal. All the parameters will be normal. Normal count, normal motility, normal sperm concentration, everything. Normal morphology, normal pH, normal volume, normal viscosity. Everything is normal to do with the semen. Normozoospermia. Oligozoospermia. Oligo means anything that is which is low or less is oligo. So it indicates low sperm count or low sperm concentration. And these are divided into mild to moderate and severe. In mild to moderate, the sperm concentration is less than 20 million per ml, whereas in severe it is less than 5 million per ml. Here, we'll study azoospermia and aspermia. Initially, during the MBBS, I had confusion between azoospermia and aspermia. So I have remembered in this way. A zoospermia. Zoo means some animal. Here the animal is the sperm. Sperm is the animal or the some living creature. Living creatures zoo. So azoospermia, this living creature is absent in the semen. So absence of sperm in the semen. Semen is produced, but it does not have any living creature inside it. That is azoospermia. Aspermia means there's no semen at all. There's no material at all. There's no material. Aspermia, absence of semen. Semen is absent. Yes, sperms are absent in azoospermia. In asthenozoospermia, astheno means weak, something which is weak or thin. Astheno means thin, that means it is weak. Asthenozoospermia means it is because of weakness, it cannot move, so decreased motility. Teratozoospermia, terato means something of abnormal morphology, something of abnormal structure. That is teratozoospermia, increased abnormal morphology. Leukocytospermia, more than 1 million WBCs per ml is said to be leukocytospermia. Oligo, asthenozoospermia, something, all the variables look abnormal, low count, morphology, all variables are abnormal. Necrozoospermia, necros means dead, necros is dead. So the sperms are dead, they are non-viable or non-motile. So these are the few terminology that we use in semen analysis. Coming to the examination of semen. The examination of semen, it is divided into physical examination. Firstly, physical. Later, we go through microscopic, immunological, biochemical, biochemical, and functional Sperm function test. We'll study the examination in these five headings. One, two, three, four, five. Physical, microscopic, immunological, biochemical, sperm function. Let us begin with physical examination. Physical examination of semen. That means what you see with your naked eye. First, as soon as you receive the sample, how it is, visual appearance. Normally it is grey, white and viscous. In some cases of prolonged abstinence, the color might be slightly yellow. And viscosity, how it is, thick it is. Semen is thick and viscous. Initially it is thick and viscous. On standing for 30 minutes, within 30 minutes it is liquefied. Because of what? Prostate produces proteolytic enzymes. Proteolytic enzymes of the prostate liquefy the thick viscous semen so that it can easily penetrate through the cervical passage. Normally, the semen falls when, if at all you hold with a capillary tube and let it falls drop by drop. If at all there are thread formation and the thread formation is more than 2 centimeters, it is said to be of increased viscosity. Increased viscosity is suggestive of infection of seminal vesicles or the prostate. Any infection to the seminal vesicle or prostate increases the viscosity of the semen, which is abnormal. The sperms cannot penetrate through the cervical mucus. It is abnormal, hence it is considered abnormal. Next, the third parameter is the volume. Firstly, you have seen uh, uh, this one, visual appearance, how it is, color and all, viscosity, how thick. Now, volume. Normally, we have studied 1.4 ml according to WHO 6th edition, and this volume is measured after liquefaction. Low volumes are generally associated with low counts, obviously. Next is pH. The liquefied semen is placed on this pH paper. It is spread over pH paper, and after 30 seconds, you measure the pH. Normal pH is between 7.2 to 7.8 after 1 hour of ejaculation. This is the end of physical examination. Under physical examination, you go through the visual appearance, that is the color, viscosity, how thick it is, volume, how much is the volume, pH. These four parameters come under physical examination. Now you see the microscopic examination. Firstly, you see motility. As soon as the liquefied semen is placed on a glass slide covered with a cover slip, you examine under microscope. The first thing that hits your eye is the motility. Motility, the first lab assessment in wet preparation. See here, all the motile and non-motile sperms are counted in randomly chosen fields, and you see it under 40x lens. And the result is expressed as percentage of motile sperms. See, if you drop one drop of semen and on the glass slide, cover it with cover slip, and you see under the 40x lens, at least 200 sperms you count. Among the 200 sperms, how many are motile? If suppose 100 are motile and the 100 are non-motile, you give the result is as 50%. Means out of 200, no. So 50% are motile sperms. 50% are motile sperms. And few terminology, rapidly progressive. Rapidly progressive. That is fast forward movement in a straight line. This is sperm. It moves very fast in a straight line. That is rapidly progressive. Progressive means this is slow linear. I mean, this is a sperm. It moves slowly in a curved way, or in a crooked way, or in a curved way, very slowly it moves. That is progressive. Non-progressive means this is a sperm. The tail, only the tail wiggles. Only the tail wiggles. This movement of the tail only, and it does not move forward. It does not progress forward. That is non-progressive. Immotile means there's no movement at all. It just sleeps like this. The sperm just stands out or sleeps like that. There's no movement of the tail, neither the tail nor the sperm as a whole. There's no movement at all. That is said to be immotile. Normally, there are 25% or more than 25% of rapidly progressive and 50% or more than 50% of rapid plus slow progressive normally in a normal sample. If the proportion of motile sperms if it is less than 50%, if motile sperms are less than 50%, then you check the viable sperms, that is how many are alive and how many are dead. You check for viable live sperms or viable sperms, and which are determined by eosin preparation. The second test after motility is the viability, how many are alive. The principle behind this is for example, there's a live sperm. It is the cell membranes are intact. Intact cell membrane, they do not take up the stain. So, live sperms are not stained. Live sperms are not stained. A healthy sperm is there. All the membranes are intact. The head, everything membranes are intact. If at all you put a dye on it also, they do not take up this dye. Membranes are intact. They do not absorb the dye. So they are not stained. They look like translucent white under the microscope. Unstained sperms are live sperms. Whereas the dead sperms, because the cell membrane is damaged. For example, this is a dead sperm. Here and there are nicks. The membrane is damaged. If at all you put a dye into it, it takes up the dye. It goes inside the sperm. So stained sperms are dead sperms. These are the stained. This is the stained sperms. These are dead sperms. While the unstained sperms are the live sperms. And eosin stains the sperms, whereas nigrosin stains the background. In this method, you mix one drop of semen with one drop of nigrosin stain. You mix it well, and one drop of this mixture will be placed on the glass slide. You make a smear of it, you let it air dry, and you stain it and observe under oil immersion 100x lens. The white sperms, unstained sperms are live sperms, whereas the red sperms which have taken up the dye are the dead sperms. After viability, firstly you check the motility. If motile sperms are low, you check for viability. Next, thirdly, now you do the counting. How many number of sperms are present, you do the counting. And this counting is done after liquefaction. After liquefaction, you've done the counting. The semen will be diluted with 1:20 dilution you take with sodium bicarbonate formalin diluting fluid. After diluting, you load the newbar chamber with this mixture. You cover it with cover slip and leave for 10 to 15 minutes the sperms so that the sperms settle in the chamber. Later, you observe it under 40x lens. Four large corner squares for this is the newbar chamber. This is for RBC corner. RBC. This is the RBC square. These are the WBC. Large corner squares are the WBC squares. So here the four large corner squares you take. Corner squares are counted for semen. Four large corner squares are examined, and uh, the sperms are falling on the upper and the left margins. They are also counted as within the box. The sperms counted is a formula for the sperm count. You count in all the four chambers, right? You note it down, number of sperms counted into correction factor that we have diluted as 1:20. Correction factor into 20 you divide it by number of squares counted. You have counted four squares and volume of the square, that depth zero point 0.1 zero point 0.1 cubic millimeter, and you multiply with 1000. This is the formula for sperm count. So n is the number of sperms that you count, n is the number of sperms that you count into correction factor. Since we have used 1:20 dilution, correction factor will be 20 into number of squares counted is 4 into depth or the volume is the 0.1 cc into 1000 I'm doing. So you take this decimal up. So n into 200 by 4 into 1000, this will be 50. So n into 50,000. This is the formula for sperm count. This is the direct formula for sperm count. N into 50,000. If at all you get 500 sperms, you counted 500 into 50,000. This is how you get the sperm count. After motility, viability, sperm count, lastly morphology. We go and examine, we check for the morphology. A normal sperm has head, neck, tail. These are the three parts of a sperm. Firstly, see here, this is a normal sperm. It has head, this is the neck. From here to here, everything is the tail. So head normally it is pear-shaped. The anterior two-thirds will be covered by acrosomal cap. It is pear-shaped. Anterior two-thirds covered by acrosomal cap. It has a nucleus. Head has nucleus. DNA present within the head. Neck is short. It has centriole, which gives rise to axoneme of the flagellum. This is the neck. It is a short segment. This is the centriole. It continues as axoneme of the tail. The tail has three parts: middle piece, principal piece or the main piece, and the end piece. Middle piece, main piece, end piece, three parts of tail. The middle piece has central axoneme. Axoneme will be surrounded by so many longitudinal fibers. For example, this is the cross section, central axoneme. Many longitudinal fibers, and also they have elongated mitochondria. Elongated mitochondria. Mitochondria gives energy. Energy for the tail to wag its tail and have a movement. It is required for motility. This mitochondria required for movement of tail. Now this is the principal piece. It has a central axoneme surrounded by exactly 9 longitudinal fibers. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 longitudinal fibers. End piece is short, tapering, it has only axoneme. The end piece is short, tapering, it has only axoneme. This is the structure of a normal sperm. If at all there are defects, if at all there is a defect in the middle piece has mitochondria. Anything to mess up with mitochondria, there will be no energy, so the motility will be decreased. Secondly, there is a defect of acrosomal cap. Acrosomal cap is required for penetration into the ovum. If at all that cap is not present, it cannot penetrate into the ovum. And if at all giant head indicates defective DNA condensation. Condensation of DNA is defective. So that indicates giant head. And a few problems with the morphology of sperm. This is a normal sperm. This is the morphology of a normal sperm. If at all this is a giant head, comparatively the head is larger. Giant head. This is a smaller head. This is a tapered head. Sorry, this is a tapered head. This is a tapered head, that is elongated tapering kind of. This is a pyriform head. Pyriform. This is round heads. These are amorphous, means it does not have specific size or shape. Here it has vacuoles within the head. It is a round head without an acrosome. This is the acrosome. Here acrosome is absent. There can be double heads, multiple heads can be present. This is the pinned heads. Here there is no acrosomal cap and the middle piece is very thick, thick middle piece. Here problem with the tail, coiled tails, bent tails, or you can see here two tails are present. One, two. It splits into this tail, splits into two double tails. So all this abnormal morphology, these are not taken into consideration while doing sperm count. All these forms are not counted. These are abnormal forms. Coming after the physical exam, we have done with physical examination and also microscopic. Thirdly, immunological assay. In immunological assay, immunological means studying the antibody or antigens, antibodies. You must have heard about this anti-sperm antibodies. That is, the human body itself, it produces antibodies against its own self, antibodies against the self sperms. These can be present in the serum, semen, or cervical mucus. Antibodies are produced against the sperms. So these anti-sperm antibodies, they either immobilize or kill the sperms or prevent their passage through the cervix. The antibodies that are bound to the head prevent penetration into the ovum. With the tail, it prevents its motility. There are two tests, mixed antiglobulin reaction. Firstly, we have studied these two tests in the normal parameters according to WHO. So, mixed antiglobulin reaction test, and there is immunobead test. Two tests are there. Firstly, study the sperm mixed antiglobulin reaction test. It can detect both IgG and IgA antibodies against the sperm surface in semen sample. Let us see the direct test. Direct sperm mar IgG test. So you from the patient or from the individual, from the male partner, you take one drop of fresh unwashed semen, mix it with IgG coated latex particles and add to it anti-human immunoglobulin. These three are mixed on a glass slide and you examine. At least 200 sperms are checked out for. If at all there are antibodies on the surface of sperm, this is a sperm. If it has antibodies on their surface, this anti-human immunoglobulin, it will attach this latex, it will attach the latex, IgG coated latex to this antibody on the surface of sperm. If antibodies are present on the sperm, the immunoglobulin attaches the latex particles to this antibody on the surface of sperm. So, whenever under microscope you find a motile sperm with attached latex particle, that indicates the sperm has antibodies on their surface. It is proven that antibodies are present on the surface of sperm if at all latex is attached to it. This is a direct sperm or IgG test. Whereas if at all sperm they do not have antibodies, motiles, you find motile sperms without attached particles. The immunoglobulin will not attach the latex to the sperm to any antibody because the sperm does not have antibody. The latex cannot attach to it. So without any attached particle means the antibodies are absent. This is a direct sperm or IgG test. Coming to direct sperm or IgA test. In IgA test, from the patient, you take one drop of fresh and unwashed semen. You mix it with IgA coated latex. There is no immunoglobulin here. You mix it on a glass slide. If latex particles they bind to sperms, they coated with IgA antibodies. If at all sperm has IgA antibody, this latex particle directly goes and attaches to the antibody on the surface of sperm. So whenever you find a motile sperm with attached latex particle, then it is positive for antibody. These are the direct tests. In indirect test, indirect means you do not take the semen with the antibody as such. Serum is analyzed. Serum is analyzed here. Antibodies are bound to the donor sperm. You take a donor sample, antibodies attached to the donor sperms, and this is mixed with the serum. Now you check for the antibodies, like as you perform for direct test. You add the immunoglobulins, latex also. Immunoglobulin coated latex. If at all the latex attaches to the semen sperm, antibodies are present. If they do not, antibodies are absent. If more than 50% of sperms with attached latex particles are present, there is a serious immunological problem. There is a serious immunological problem if more than 50% of sperms show these particles. This is about the mixed antiglobulin reaction. Mixed antiglobulin reaction. Next, we'll study about immunobead test. Immunobeads are plastic particles. They are plastic particles, and they have this anti-human immunoglobulin on the surface. This is a plastic particle. They have either IgA or IgG or IgM particles on their surface. Now you mix it to the semen sample. If antibodies are present on the surface of sperm, they are detected by these antibodies bound to the immunobeads. So the immunobeads come and attached if at all the sperm has antibody. This immunobeads, the plastic particles, recognize this and come and attach to it. So 200 sperms are examined as before. If more than 50% of sperms show attached beads, then it is considered abnormal. This is regarding immunobead test. We have done with the immunological assay also. Now let us study about biochemical analysis. In biochemical analysis, main important thing is for fructose. Fructose secreted mainly by the prostate, by the seminal vesicle. So the test performed is resorcinol method. 5 ml of resorcinol agent mixed with 0.5 ml of semen. They are heated or brought to a boil. After 30 seconds of boiling this, you get a red color. If you get a red color precipitate, fructose is present. Fructose gives you red color. Fructose gives you red color. Okay. If at all, while performing semen analysis, while you do a sperm count, you find azoospermia, absent sperms, you go for biochemical analysis. If fructose is absent, there's no fructose, you do not give it does not give a red color, fructose is absent. That means there's obstruction of ejaculatory ducts or vas deferens. That means uh, there's a problem lying proximal to the seminal vesicle. Proximal to the seminal vesicle. I mean, seminal vesicle, it secretes a fructose. Fructose is absent means the problem is behind seminal vesicle. It can be at the edge, obstruction to the ejaculatory duct or vas deferens. If at all fructose, I will give you, let us come to the first image. For example, this is a seminal vesicle. He is here. Seminal vesicle is here. This secretes fructose. It secretes fructose. If fructose is absent, that means the semen is not at all reaching here. Not at all. The problem is not here. It is behind this problem. It is behind the seminal vesicle. It can be either vagina, vas deferens, or the ejaculatory ducts, Nothing to do with the seminal vesicle. If sem if fructose is present, that means seminal vesicles are good functioning. So uh, testes have failed. The testes have failed to produce the sperms. Testes have failed to produce the sperms. Problem with the testes. There's no problem with seminal vesicle. After biochemical function, you do a sperm function test, that is functional analysis. These are done only in specialized andrology labs, and these tests are non-specific, means these are not confirmatory. This test, along with in conjunction with other tests, you can come to a conclusion, not alone with functional tests. Few of the sperm function tests are firstly post-coital test, as the name suggests, after coitus test. or Sims-Hunter test, after coitus test. In postcoital test, you examine cervical mucus after the intercourse to know the ability of sperm to penetrate the cervical mucus. So, for example, if the time of ovulation is said to be 14th day of cycle, 14th day of the cycle is the ovulatory day. Just in and around 14th day, that means half a day or uh, a night before the 14th day, on 13th day night, you ask the couple to meet, to have an intercourse and come to the lab as soon as possible, like within 2 to 12 hours. Cervical mucus is aspirated with a syringe before expected time of ovulation, 2 to 12 hours after the intercourse. And you do gross and microscopic examination of that cervical mucus to assess the quality of cervical mucus. What is the quality? Like you check for elasticity and drying pattern. Normally, what are the normal parameters? Normally, when you examine the cervical mucus, it shows normal amount of sperms and they are moving forward in the mucus. And the mucus, the elasticity stretches at least 2 inches. It stretches at least 2 inches. And drying pattern dries in a fern-like pattern. These are the normal parameters. What is said to be abnormal? When you check the cervical mucus, it does not show sperms, absent sperms, or clumps. All the sperms that clump together. They do not move, they clump. Or there can be dead sperms. That means it has taken the eosin dye. Dead sperms are present. Mucus stretching there, it cannot stretch beyond 2 inches. And drying pattern do not dry in a fern-like pattern. These are the abnormal parameters when you do a postcoital test. Another test is cervical mucus penetration test. In this, you take a capillary tube. First, this is filled with bovine mucus. Bovine mucus, you fill it up with bovine mucus and you add the semen sample from the male partner and you measure the greatest distance traveled by sperm in the seminal fluid placed in capillary tube. Normal fertile, in a good fertile men, the distance traveled by the sperm will be 30 mm. That is, you add to the bovine mucus, it travels a distance of 30 mm. This is said to be fertile. If it is infertile, it is less than 20 mm. Less than 20 mm is infertile men. Infertile men. Another test is thirdly hamster egg penetration test. Hamster egg penetration test. In this, the hamster eggs are enzymatically treated to remove the outer layer of oocyte. This is the egg. It has an outer layer. This outer layer prevents cross-species fertilization. When if you add a human sperm, it prevents the fertilization. To remove this quality, to remove this function, it is treated enzymatically to remove the outer layer. Now, when you add a human semen, it can take up, it can be penetrated by the human sperm. So these eggs are incubated with sperms and observed for penetration. You check for number of eggs that can be penetrated, and you take in one egg how many sperms can penetrate. For one egg, how many sperms can penetrate? Firstly, number of eggs penetrated. If at all you take 100 eggs, out of 100, how many are penetrated? If it is less than 15 eggs that are penetrated, then it indicates low fertility. At least more than 15 or more than 15 eggs should be penetrated by the semen of a male partner. That indicates good fertility. And number of sperm penetrations per egg. If you take a hamster egg and one egg is fertilized by how many sperms? It should be at least normally 5. Normally, it should be more than 5. One egg fertilized by more than 5 sperms is considered normal. This hamster egg test, it detects sperm motility. Obviously, it has to travel up. Motility, binding to oocyte, penetration. Lastly, examination for presence of several medico-legal cases. In case of rape or sexual assault, you collect the sample from the rape victim, like vaginal fluids, clothing, and you examine for presence of semen. In case of clothing, you take a piece of like a 1 square inch of the clothing you take, you scan it under ultraviolet light, If semen is present, it gives green-white fluorescence. In ultraviolet, it gives a green-white fluorescence. Then semen is said to be present. Few microscopic examination for sperms are when you collect this vaginal fluid, if motile sperms are present, that means it indicates an intercourse within 8 hours. Within 8 hours, intercourse has taken place if motile sperms are present. And in vaginal fluid, you perform biochemical test. Acid phosphatase, if it is positive, acid phosphatase is present and the levels are more than 50 units per for one sample, semen is said to be present. And also, if semen is declared positive, you can also determine the blood group substances. Because when semen is positively identified in vaginal fluid, tested for blood group substances, because 80% of the people, 80% of individuals, secretants. They secrete blood group substances in their body fluids like saliva, urine, sweat, semen, including semen. If semen is present, you can check for the blood group also. And lastly, you can do a Florence test. This is a biochemical test. You add the choline is present in the semen, which can be detected by Florence test. Lastly, you examine semen to check the effectiveness of vasectomy. So after vasectomy, follow up, you ask the patient to come and give semen samples 12 weeks, 12 weeks or 15 ejaculations after the surgery. Two consecutive, two successive or consecutive semen samples. If they are negative for sperms, then the semen is free from sperms. You ask the patient to come after 12 weeks, that is 3 months after the surgery, or 15 ejaculations after the surgery. You collect semen samples for twice you collect. If two consecutive, one by one samples are negative for sperms, then the surgery is successful, the vasectomy is successful, and semen is totally free from the sperms. This is all about the semen analysis. Thank you all, guys.